I do represent two products. One's called Indiba, which is sort of leading radio frequency, but tonight we're really talking about K laser and the other gait analysis machines under George's portfolio. I've been working with lasers for well over 15 years now. And I was introduced to K laser back in 2010. And it's become a really key part of what I do and what I've been involved in. We work in many, many areas, but the fundamentals of lasers, they're unlike a drug. There isn't a sort of a specific molecule which then changes according to the dosage or the concentration. It's a lot more complex than that. So lasers are made up of wavelengths that target specific molecules in the body, which then have a knock-on physiological effect for circulation, for cell metabolism and oxygenation of tissues. They vary dramatically in power. Um, and the main benefits of power is in order, whether it's a skin injury, whether it's a musculoskeletal, whether it's arthritis, or whether you're using it for some minor surgery procedure, dosage is important. And we try and optimize the dosage, whether it's for healing or whether it's for cutting things, so that we can do things as quickly and as efficiently as possible. And definitely class 4 lasers allow you that because you can go from a very low power to a high power. And then the fine tuning, the oil of the product is the frequencies because different pulses, and that's the amount of time a laser's on per second, allows you to do things as varied as healing wounds to being able to improve blood flow, to reducing pain and inflammation, and then also stimulating different soft tissues to bone structures. So the combination of the three makes it quite complex, but hopefully our technologies and our training makes it relatively easy for people to be able to utilize. And we see that because we work across a broad church, from dentistry to podiatry to MSK to arthritic clinics to elite sports. And so it can be really used on a wide range of different aspects. And from a sporting aspect, it can be used pre-training. So we'll work with a lot of the Olympic teams, and we'll be working with the sports clubs as well, and their franchises where they're using it for potentially susceptible injuries. I'm trying to make sure they don't become major injuries. You can nip things in the bud earlier. Often in general practice, you don't see these as often as they do in elite sports. But what you will be seeing is sort of an acute inflammatory or an active sport injury where they're coming in and obviously quite lame when they do that in that process coming in, or they might have restricted motion and movements. Major injuries, we can use it as part of a combined therapy, along with all manual therapy, podiatric treatments, and obviously alongside drugs and surgery. And you can also use it post-surgery as well, to speed up the healing, to speed up the quality of the healing, and to reduce some of the pain and the inflammation so you can get your patients back up and active earlier than they would usually. And this is definitely some of the things Jamal will be seeing up in his more elite sports clinic that he's working with. Overall, we're not trying to take away good medicine. We're just trying to go and improve using really good modern day technology to improve what we can do within our clinics, and also alongside other good drugs and surgical techniques and other manual therapy techniques. So all the devices and everything else out there. We work across elite sports, and there's no doubt the earlier you use a laser, the better and the more complete the healing is, and the less scarring you get. Therefore, you can get back to compete at this high level. The majority of us aren't competing at this level. We're just happy to be able to do a few jogs. And therefore, for the majority of us, there is a range of things that you could use it from, especially in the podiatric world, from the musculoskeletal injuries on the left-hand side and the arthritic changes and the tendon injuries, to other post-surgical neuropathy problems, diabetic and venous ulcers. And then with a high power head, you can do ingrowing toenail surgery, verrucas, onychomycosis. So it really does a huge amount. And one of the reasons is because it is a class 4, you can do this diversity and range of different treatments from a wound right through to a neurological injury through to a minor surgical procedure, which is why it's grown so well in the podiatry world, but it is also used across the board from physios, chiros, and osteos, and sports therapists in the musculoskeletal rehab world. This gives you, I know a lot of the audience are podiatrists, and this just gives you a little overview, a little bit biased towards podiatry. Here you can see using it with the podiatric head, where you are able to ablate verrucas and do it very effectively, even without local anesthetic, which is a bit unnerving the first time when you see a smoke plume come out of the foot, but actually often it requires no local anesthetic at all because you're burning tissues that are not innervated. In regards to some of the other aspects of this, we go to the next bit. You can see here that's a therapy head. So after treatments, or we might have done a little ingrowing toenail surgery, or might be doing onychomycosis, and we can use a therapy head afterwards to speed up healing and to improve some of the blood flow. There are a number of different heads that are possible to be used. You can see here using it on a diabetic ulcer. It's a twofold process. So although we treat the ulcer itself with a relatively low power, we would also treat the whole of the lower leg. And we've gone and published papers both on venous and diabetic ulcers, and got individual papers on blood flow improvements as well. So we are using this both in NHS and in private healthcare. And then you can see here also we're able to penetrate down into the musculoskeletal neurological aspects of the foot. And here's someone with Morton's neuroma. We can reduce the swelling and the inflammation around the inflamed nerve running within the foot itself. We can treat plantar fasciitis, and we have a range of different aspects that we're able to go and do. This goes and shows you briefly onychomycosis. So we're just ablating the mycotic tissue, and then we'll use maybe a therapy head after that to be able to do that. And then you can also see here from a diabetic ulcer how rapidly we can heal. On average, we were healing diabetic ulcers in 4.6 weeks, and these were people of 3-year standings of non-healing ulcers. So it can be a really very useful product for being able to treat these aspects. And again, you've got a picture there of a gentleman for the first time being treated, happily chatting away, as the podiatrist is happily ablating his verruca. You can see we've stained it dark there because we're wanting to concentrate the actual power of the beam just over the verruca and not over the normal tissue within the actual foot itself. Overall, with different heads and our built-in protocols, it's a very easy piece of technology to adapt. It's very portable and profitable to be able to do. Unlike a lot of technology, there are no consumables, so you can use them again and again, and the only thing you have to use is electricity and a bit of brain power. It is covered under most insurance policies, and we do all the training, and we do have centres around of excellence as well around the UK, and we help you in regards to some of the marketing and the back office and the ongoing education. So it covers a wide range of things, and we have a training academy down in London, but we have centres over the UK as well that help. And we have a lot of online portals and examinations and videos and webinars, which you're able to go and access as well. So it's a complete aspect in regards of that. And overall, you've got benefits to the patient in regards of it. And then obviously from a clinic point of view, it's a nice piece of technology that covers multiple bases, and can be used by trained members of staff. That is the summary of it. Thank you for that. And if there are any questions later on, I'm happy to answer them. I will pass over to George now. Thank you.
Stephen. Hi, everyone. I'm just going to pop a quick link in the chat. Myself and Stephen co-hosted the webinar a couple of months ago, I think it was, Stephen, maybe less than that. which is more of a broader introduction to both of these technologies. So this is kind of a part two follow on from that. So I know there's people in here that watched the first one. If you didn't and you want to have a little look at that, next week or at some stage, please feel free, where I'll go a lot more into detail about the technology itself. For this evening, I'm going to keep my part extremely brief, just to give you a bit of an insight if you haven't come across Gait in Motion before, in terms of who we are and what we do. Those of you that get around to trade shows or conferences, like the Royal College of Podiatry Conference, for instance, may well have seen this team around the country. So we are Gait in Motion Technology, and the company was founded in 2018, so we're just approaching our 8th year. We provide a vast range of cutting-edge biomechanics solutions across private healthcare, the NHS, universities, colleges, and elite sport. It's very vast. We have tools starting from handheld range of motion measurement devices, something that could be applied in any clinic, from head to toe. We have devices for measuring strength, such as our Easy Force device. So we can quantify both range of motion strength as part of the basic physical examination at the start of a biomechanical assessment. More recently, we introduced easy-based dual force plates, which are vastly utilized across healthcare as well. We can look at things such as jump testing, balance, sit to stand, squats, upper body testing for strength. So really versatile tools, again, just to give data to clinicians to help with their decision making, and also progress tracking throughout the rehabilitation process. We have smaller tools as well, such as Barabas, which is an inertial sensor. Again, a vast range of tests, but really popular from a gait analysis perspective, enabling you to look at the 3 planes of dynamic pelvic movement, both when walking, jumping, etc. So that's quite a nice little tool as well. We are most known for our Footscan pressure measurement technology, which obviously forms the basis of this evening's chat. Footscan has been around for many years, but continues to innovate and accelerate in its field. We're now able to directly integrate static 3D scans as well, enabling you to blend the 3D scan with the dynamic pressure data, which has given a whole new dimension to foot and lower limb analysis. And again, lots of different applications Footscan allows from an assessment perspective. Integrated into our Footscan technologies, the ability to prescribe fits, which are the world's first dynamic data-driven 3D printed devices, which again have very much evolved over the last 8 years since we launched in the UK. We're actually launching a new range of fits in the next few weeks called Fits Dynaprint, which is a softer device as well, and a much quicker turnaround time as well. So yeah, you might have come across fits. We now have over 500 clinical partners nationwide that have the Footscan and Fit service, and they all join a national patient referral network called Gait in Motion Clinics. So the goal of Gait in Motion Clinics ultimately is to onboard clinicians like yourself, level up the gait analysis service, the biomechanical assessments, and also the data-driven aspect to orthoses. So really trying collectively as a group to keep pushing the boundaries of what's possible. And our development is very much driven by clinicians. Both Emma and Jamal in this call have played a part in that over the years as well, in terms of beta testing and development ideas, which we're very grateful for. So, as I said, I'm not going to go too mad at this end. If you do want to learn any more about Footscan Fits or any other tools that we have, I'll put my contact details on the next slide. Feel free to get in touch. But really this evening is about hearing it from a clinician's perspective. So both Emma Price, who is a podiatrist, and Jamal Mashlab, who is a physiotherapist, have used Footscan, I would say, for probably 6 or 7 years. And yeah, both done tremendously well with the service, alongside K-Laser as well. So it's quite nice to hear it from a clinician's perspective in 2 different aspects of healthcare. So my contact details are here. Feel free to throw any questions into the chat or to reach out at any time if you'd like to explore this technology further. But yeah, that's enough for me. I'm going to hand over to Emma Price for the next bit.
Thank you for inviting me. All right, so I'm going to run through some case studies. This is how I use both of these brilliant bits of tech in my clinic. I'm just going to share my screen. So I'm based in Cheltenham Spa in Gloucestershire. And I have a business called Supafoot. I have a team, a lovely team you can see there of 10. But I'm also involved with the Hive, a brilliant business coaching group. So I'm now coaching businesses to grow their teams and grow their businesses if they wish to. So I have sort of a dual role. So I'm a clinical director and a business coach as well. Alrighty, so how do I use these two bits of kit? So I'm going to start with an example of K-laser and how I use that. So this was a horrendous abscess. A professional footballer came in from a local team, had a huge infection from an abscess on his toe, his hallux. He had a dodgy pedicure, essentially. And the head of medical at the football club called me after having a surgical debridement. It was quite a big deal. It was a very, very big issue. So a local orthopedic private guy debrided the wound surgically. I had some serious antibiotics as well, IV for a while. It was a big problem for him, obviously, as a footballer. So I don't have any photos of the first two. I can't quite explain why, but anyway, I saw them on the 29th of July. I applied the wound healing setting with the K-laser. It started off with a 9mm depth wound and a 7mm width. By the 31st of July, this wound, again, had the wound healing setting on the K-laser. It had gone down slightly in a couple of days from 8 by 6. Sorry about the lack of photos there. But I continued. I said, look, this is starting to look much better. Let me keep seeing him. So I do now have some photos for you. The 2nd of August, we had a 6mm depth there. It's pretty bad. But all of a sudden, as Stephen alluded to earlier, the healing just exploded. Well, not exploded, it accelerated. So 6th of August, a few days later, it was at 3mm, 2mm, as you can see. The physio and the team doctor were sort of rubbing their eyes, kind of like, how has this happened? And then they took over after 10 days of my intervention. So the orthopedic surgeon was very impressed as well. They said, no way is he going to be back before mid-September, possibly early October. And we got him back training in mid-August. And he was playing 2 weeks later. Such was the skin integrity, it was fine. So he was able to not play a full game, but he was still able to play. So that was a massive success. The healing was unreal. So that was a big win. And now a very strong referral partner. So that's always nice. I'm going to go through these quite quickly because I want to just give the other panelists opportunities to answer questions and things. So case study 2, this is a really nice one. This is very recent, December 2025. So this chap, 78-year-old chap, came into our clinic, very, very arthritic right ankle, only had 30 degrees of dorsiflexion in that ankle, very, very painful for him, very long-standing injury. I think it was a ski accident 60 years ago. He's got a pretty cavoid foot as a result of this. It's upside down. Apologies, I don't know why, but this is the offending foot, really sort of leaning back on the heel, not walking well on it at all. So we used the Footscan to identify some biomechanical anomalies, and based on what we could see mechanically, we wanted to give him an orthotic. So we gave a trial orthosis. When we have a cavoid foot, particularly the way we practice, we often like to give a trial. If we're going to give a lateral post, that means to pronate them a little bit more. We had a very cavoid arthritic lateral column, so we wanted to pronate him slightly. So we didn't give him fits at the moment. We just wanted to trial and see how he coped with a long lateral post, but is very, very interested in having some fits in the future. So alongside these trial orthotics, we offered K-laser to calm his pain down. So we did 2 a week and gave him some gentle ankle mobilization exercises. So he was seen on the 20th of Jan, yesterday, and his pain is now 3 out of 10. So he's gone from a sort of an 8 out of 10 to a 3 out of 10 consistently, very, very happy with a combined therapy. And he's now asking us to prescribe him some fits based on our prescription. We were checking the reason we do a trial orthotic and we wouldn't have gone straight for fits in that case is because we just wanted to make sure that the long lateral wedge wasn't going to affect his knee. And make sure that he was able to walk comfortably with that posting. So we're going to rescan him after his final laser session next week. He's absolutely delighted. And we've managed to get him away from the possibility of a corticosteroid injection at the moment. So the referring doctor, again, another private doctor, is very happy. Like, this is a really great outcome. This patient's really, really happy. So this is a nice example of how we're combining those two things using the power of both K-laser and fits, Footscan. This is a common sight. I'm sure all of us will have seen these if we're podiatrists, bilateral plantar metatarsal pain and toe pain. So this is a pair of feet here, very evident fat pad loss, very rigid first raise, right hallux valgus, hallux limitus, non-weight bearing. The right second, left second, and third sit lower than the rest of the toes. So the toes are there's a lot of muscular inadequacies there. Very prominent metatarsal heads. You could read the assessment there, but essentially there's a huge mechanical deficit going on. Lots of reduced ankle range of motion, midfoot, subtalar joint. All of those joint ranges of motions were reduced. So not a happy lady. Very high, quite a high foot posture index, +8, had a genu valgum, was very externally rotated, wasn't using her big toes at all. You can see they're sort of floating in the air. She's very heavy weight bearing through the first met heads. You can see the extensor tendons sort of pinging as she's walking, and there was no dynamic movement on weight bearing through the first ray at all. So sorry, it's cut off the text there, but this patient actually came to us. She's already been given some really chunky EVA devices, really nice orthotics, but she can't get them in all of her shoes. So she was really struggling with footwear because she's got quite a big foot anyway, and wanted to know if we could offer a slimmer device. So huge medial knee pressure on the left foot that we could see, medial heel pressure, and the right foot first met head is doing a lot of the work very early in the gait cycle. So the key points that we saw were evident, particularly here. And we've got this huge sort of spike running through. Let me take you just through to the video. That's a bit more helpful. So what she's really doing, the way I would interpret this is, she's really sort of slowing down. If you watch again, I can't make it play again. There we go. Certainly on the right hand side, if you can see my cursor there, there's a big pronatory moment going through that right foot, particularly here, yeah, it's quite obvious needs correction. So we gave her a 4-degree varus posting as per her old EVA devices, reduced the navicular height slightly because she's quite flat-footed, kept the heel height as 0 because the requirement of the patient was that she wanted these to fit her shoes. Gave her a normal lateral arch height. If you don't use fits or Footscan, this might not mean a lot to you, so apologies if I'm rattling through, but we gave her an extension to help with her first ray problems, and a met dome bilaterally to try and support the foot. And we gave the shell a slight widening as well to account for the swelling that was there. Another really interesting point with this patient, and this is where Footscan and fits work really well, is that this patient has very advanced hand OA. So the fits were far easier for her to move between her shoes than the bigger, chunkier devices. And she needed a lot of support. So we needed something that was going to hold her and that we could really make rigid. And we were able to achieve this in fits with a much slimmer device than she already had. So this is a huge win. She's delighted. Next case study. This is a nice one. So retired dentist, now a very active gardener and beekeeper. He's very proud to tell us that. His pathology was a very slow onset of his left second met head, plantar plate dysfunction, very classic sort of floating second toe. Pain on pressure, pain on standing. It was 10 out of 10 for moderate periods of time, just sort of standing around doing his thing. So pretty unhappy chap. You can see the huge pressure going through his second met heads there. So we used a Footscan to identify and just take a look at what was going on mechanically. He also had that classic sort of floating toe. So what did we offer? We offered offloading orthoses. So again, this patient opted to try an over-the-counter device that we altered slightly for him with an offload and a pour-on button to sort of offload that second met head. We gave him some strapping provision and taught him how to do this. So it was actually a sort of a figure of 8 strap to pull his second toe down to try and reduce the tension going through the plantar plate underneath. And we gave him 6 sessions of K-laser therapy to reduce immediate inflammation and pain because he was in a serious amount of pain, pretty much unable to walk. So we gave him 6 MSK laser sessions over 2 weeks on the foot pain setting. We did 2 passes over the met heads and generally plantar dorsal surrounding areas. So, and this was last year, but we've checked him out and he's still pain-free. So late Jan to mid-Feb, we gave him these sessions. He loved his insoles. He loved the combination therapy of the K-laser and then the orthotics that we gave him. We said, right, well, let's make these a bit more permanent because the over-the-counter devices we used would eventually peter out. So he's ordered fits with the same prescription. We reviewed him and fitted those in March 2025. He's basically 100% pain-free with our interventions. He's only in pain when he's not wearing his insoles. And we've checked in with him 6 months later and he's still pain-free. So this is a huge win. And it was the combination of really being able to identify exactly where on the foot that pressure was and being able to see that with our own eyes and show him, this is what's going on, which always helps. You know, the patient journey is, and the psychology behind, like, I can see that's where my pain is, it's red. That really does help. We have a huge screen in our Gait lab and they can watch the recordings of their gait and we can explain what's going on and why. We can then say, look, we're going to offload that for you using this prescription. Fantastic. Straight into the K-laser to calm everything down. And the combination of those 2 things work beautifully. So another very happy customer. I wasn't sure whether to include this, but I thought, why not? Let's do it. Financially, in the last 3 years, I've turned over £72,000 with K-laser and £79,000 with selling fits insoles. So in terms of the benefit to my clinical practice, these 2 things both are turning over good money, really good money. Obviously, they're paying for themselves over and over. And once you've got the systems in place, they don't cost you anything to maintain. So I'm very happy with how they are allowing me to make money as well. The clinical outcomes are first and foremost, of course, but hey, we're in our clinics to gain financially as well. Of course we are. So these have both been very successful for us. And that's me.
Thank you, Emma.
Thanks, Emma. That's nice to hear. I didn't know what you were going to show us there this evening. So,
They were good case studies. Really interesting. Thank you.
Perfect. Should we move on to Jamal before going through a Q&A just to keep it flowing through?
Yeah.
So I think from Jamal's perspective, this is going to be more of an open discussion really on Jamal's experience rather than slides. So we're mixing it up a little bit. So I guess Jamal, I'll I'll pass over to you to talk about your experience with the technologies. I don't know how long you've been using K-Laser, but I know Footscan, we've been working together some time now. So I shall leave it with you.
Jamal, do you want to give a little background about your clinic and where you are in the world?
Yeah, indeed. First and foremost, I just want to thank George and Stephen for inviting me to speak to all these wonderful practitioners that are listening to us tonight. My name is Jamal Mashlab. I am the clinical director at the Lilleshall Clinic. The Lilleshall Clinic, basically, it's a private practice, but it sits within the National Sports Centre at Lilleshall, which is a centre of excellence for Olympic sport. My background is I was technical lead physiotherapist for the UK Sports Institute, based in between basically West Mids between Birmingham and Lilleshall itself at the High Performance Centre at the Alexander Stadium in Birmingham, as well as at Lilleshall. And I was head physio with several Olympic teams, and then moved on to acquire the Lilleshall Clinic in 2014 as clinical director. We see a huge variety of patients, from your elite sports to your 95-year-old that is struggling with mobility and everything in between. Basically, we see young gymnasts who are 7, 8, 9 years old, and triathletes who are preparing for Ironman, as well as your regular cyclist, runner, etc., but also the general public. So it gives us a huge amount of exposure to not only the athletic world, but your general everyday person who perhaps sits in the office for 8 hours a day and then goes out for a run and injure themselves. Or actually not run at all and have all sorts of back problems and things like that.
Like me.
Yeah. So that's in a nutshell my background. We are a multidisciplinary clinic, so we do sports rehabilitation. We have a state-of-the-art rehab gym. And so we do biomechanical assessments, podiatry type assessments. We obviously, hence why I'm here. We work with fits insoles, but also the Footscan system, which is, I think it's an amazing piece of kit. And probably in the last, I would say, year, Stephen, maybe or so, we've taken on K-Laser, and we've been offering that. And I have to admit, from my experience, having used both systems and modalities, it's significantly enhanced what we can offer our patients. So what I'd like to talk to you about today really is not necessarily a very specific case study that is, this condition and we treated it this way, but generally how I combine those two in my practice to actually provide something quite special to the patient. Very much similar in a way to what Emma's alluded to with one of her patients, particularly that dentist, how they combine the treatment and the assessment. So we very much do that on a physiotherapy, perhaps more specific type. So as most physiotherapists on this chat listening in, we don't just have foot and ankle problems. We see knee problems, we see hip problems, we see all sorts of soft tissue problems, nerve issues from the back and everything else, MSK in general. But where these two systems come in really, really well and complement each other incredibly well is when it comes to conditions like, for example, bursitis, trochanteric bursitis, for example. When we see athletes who are struggling with knee pain, particularly runners, sometimes cyclists. We see a lot of cyclists. So I have an interest in cycling because I'm a cyclist as well, and we offer bike fitting at the clinic. So we get a lot of cyclists with knee problems, and not to mention your likes of Achilles tendonitis, tibialis posterior problems, and obviously very much like Emma, metatarsalgia issues, and other foot and ankle problems that can be either injury related, arthritic related, or biomechanically related. So as an example, in fact, one of my patients today, so he came in, he's a 54-year-old, and he effectively is an IT guy, sits at his computer all day, and he decided the back end of last year that he's going to get a little bit fit because he's got a little bit of extra timber on and he wants to lose some of that timber, and he's never run before, and he started, right, I'm going to start training for running. And anyway, cut long story short, started running. Literally within 3 weeks into his running career, he developed plantar fasciitis. Surprise, surprise. Not conditioned, probably not the right footwear at the time, which we discovered later on. He was wearing, guess what? Skechers. So he was wearing the most simple Skechers you can get, that you can bend them in two fingers and you can twist them around, no support whatsoever in the midfoot. And anyway, so he had plantar fasciitis, and when he came into the clinic, he was seriously struggling. He couldn't get out of bed without sort of very gingerly putting his foot down. Any times that he sat on his computer, he stands up to go to the loo or something like that. He's hobbling because he's in agony. Absolutely typical plantar fascia problem. So when I assessed him first, you could tell very quickly that he's generally a non-conditioned person. He's weak overall. He's got positive Trendelenburg when you're testing single leg stuff. Very weak glutes. When he's standing still, you can tell there's an overpronatory pattern. When you look at him from behind, his Achilles are bowed a little bit as a result of that overpronation at the ankle level. He didn't have any specific, horrendous foot and ankle sort of presentations in terms of no hallux valgus, normal toe, big toe extensions, normal windlass mechanism. But you could tell that he wasn't holding sort of his midfoot navicular support area wasn't very good, and it was dropping in. So we needed to look into it a little bit more. We needed to find out a little bit more. So we got him to do a full biomech assessment. We got him walking on the foot scanner. And very much immediately we could see a pattern of overpronation. There was an instability on the hind foot. He was dropping in quite a bit. Again, for those who have never used the system, you have a graph that shows you several lines that depict the area of the foot, and you can tell from those graphs how the foot and ankle are behaving in a lot of detail. So it's an amazing piece of kit to determine not only where the issue is, but exactly by how much and when is it happening through the gait pattern or the stance in effect. So we were able to determine that fairly quickly. The nice thing is we sat down, we explained that to him in a lot of detail. He was really engrossed in it, being an IT guy and looking at all that detail on the screen. He was really bought into it, which is great because when you have buy-in immediately, you can sort of move forwards with things in terms of the patient being compliant in effect. So once we did that, that was sort of back end of last year, more or less. We decided, right, we do need some insoles to correct some of those mechanics. And luckily, being on the sort of support clinical panel for Gait and Motion, we had access to the new Dynaprint insoles, which are the new Fits insoles. And being someone for that patient who has never had insoles before and wanted to use them for running, we thought we can actually use those as a first port of call, because we can make them much softer, so they can tolerate them a lot better. And that's exactly what we did. So we supported the arches at the navicular. We did some medial postings about 4 degrees for what he needed bilaterally. And at the same time, we went through a course of K laser for his plantar fascia. And we combined that, obviously, as physios always do, with some mobilizations and for some soft tissue release around the ankle, around the calf muscle and that sort of thing, to just release some of these tensions. And so we are now effectively 6 weeks or 7 weeks, actually, since his initial assessment. As of today, which I've seen him today, as of today, he is absolutely delighted with his insoles. They feel incredibly comfortable. He is now getting out of bed with no pain. He's completely pain-free out of bed. He still complains a little bit that his plantar fascia gives him a little bit of aching after a run. So he's back running 7 weeks later. And he gets out of his chair after 5-6 hours sitting on his computer, and he's not hobbling anymore. So in a very short period of time, a condition that usually takes weeks to months to resolve is now almost resolved, not quite, but almost resolved within 7 weeks. And for plantar fasciitis, any clinician that have had experience treating plantar fasciitis, they tell you it's a nightmare. So we are seeing some game-changing results when we are using the two systems together, between not only explaining to the patient what the problem is and the patient understanding it really well and why, but introducing the insoles that already are dealing with the source of the problem, and then treating the symptoms themselves with the K laser. Now, it goes without saying that alongside all of that, he's now been given a strength and conditioning program that he has to follow if he wants to continue running, to just globally strengthen glutes, hamstrings, quads, calves, etc., as well as very specific foot and ankle exercises that he's doing on a regular basis. So it's a comprehensive process that he's gone through over the last 7 weeks. And literally the conversation we had, just coincidental that happened today, he's absolutely delighted with where he is. I'll give you another example that is someone who I just discharged last week. So this is a lady in her 60s. She's not an athlete. She's just normal Joe Public, and not very fit in general. She doesn't particularly exercise, but she likes to go out with her friends and does some hikes and walks and that sort of thing. Relatively active, but not athletic, sporty type active. She presented about 4 weeks ago. This is just before Christmas, actually. She presented with trochanteric bursitis. This was confirmed on ultrasound. We luckily have a doctor here in the clinic, so we just to make sure that there wasn't anything other than a bursa. We had her ultrasound, and that confirmed an inflamed bursa full of fluid, and she was really struggling with walking. Walking was very difficult. Sleeping at night, she couldn't lie on that side. She was really getting frustrated because she couldn't go on her walks with her friends and that sort of thing. So when we delved into the history of basically what was the issue, how did it come on, etc., it transpired that historically she had a lot of problems with her feet. And she on and off struggled with foot pain, metatarsalgia issues, ankle pains, and those kind of things. But she never associated one with the other. When we looked at her mechanics, when we looked at in detail sort of what was happening during just a normal physio assessment at the time, we were able to see that there's quite a bit of issues. She had hallux valgus, she had hallux limitus on one, hallux rigidus on the other. Her knee to wall was very limited, very tight calves. She has had diagnosed historically some arthritic changes within the ankle joint, and therefore her whole mechanics weren't ideal. And her problem came on after a long hike, basically. Apart from, so to cut a long story short, we did the biomechanical assessment. We took her through the Footscan system. We identified where the issues are in detail. She ended up with Fits insoles, and that obviously one of the features was that she was internally rotating quite a bit at the knee and hip, which combined with some weaknesses in and around the glutes as well, was overloading her trochanteric bursa. And therefore, once we had the insoles fitted, we combined that again with a course of K-laser specifically for the bursa, with the bursa setting. Since just before Christmas until as of last week, which I discharged her, she was completely pain-free. And prior to that, she had weeks and weeks and weeks of sleepless nights, inability to walk, etc. So the combination of correcting the source of the problem, which is the mechanics, helping alongside that, settling the bursa, with the K-laser, we have had an amazing outcome. We've never had to send her for a steroid injection for the bursa, which can happen very commonly because they sometimes don't respond with conservative treatment. But we're seeing with the combination of those two, in this particular case, it was a great result, and the patient was delighted. I think that's enough of me talking, unless anyone wants the specifics to ask.
I think it's really nice to hear, Jamal, how you talk about it being like a two-stage approach where you're using, I guess, the foot scan almost as the diagnostic to have a look at what is going on, to then, aid your decision making, not just with the orthotic device, but as well with being able to retest over time throughout the rehab pathway. I'm pleased to hear you got on well, or the patient got on well with the Dynaprint as well. I think that's kind of one of the reasons we've introduced that. Obviously, Fits have been tremendously successful, but aren't necessarily soft. So, Dynaprints come in as that intermediate soft solution, particularly for those that perhaps can't tolerate a more rigid style device. So,
absolutely,
that's really good to hear.
The beauty of the Dynaprint is that you can alter the stiffness from really, really stiff and rigid to quite soft.
Yeah.
I'm finding more and more now that I've started using them particularly in the younger generations, younger patients who are still growing and very active, they
Yeah.
seem to be tolerating them much better than the more rigid insoles.
Nice. That's good to hear as well. And it sounds like you almost put it in as that intermediate option prior to a potential fix for that chap as well.
Yeah.
Again, that's one of the things of bringing it in at a slightly lower price point. I think that can work quite nicely with perhaps Fits Plus being that more long-term solution. In future, he might just love the Dynaprint and stick with those ongoing. But yeah, that's really nice to hear. Stephen, there's been a few questions come through, and I've got a few that came in prior to the webinar. Is there anything else that you wanted to discuss or ask Emma and Jamal, or should we head on to
Yeah,
an
no, that's
open
fine.
sort of Q&A?
Yeah, I'm sorry for being faceless in this webinar, but yeah, thank you, Emma, and thank you for Jamal for your presentations there and talking about your experiences. And I think I mean, I've been to both your places, and they are fantastic. And if I was a patient, I would definitely come. I think the other aspect about it is the utilization of your teams as well. And it's nice when I've been along how both bits of equipment have allowed and been utilized and uptaken so well by your teams. So you're very collaborative in both your setups there. So giving the objectivity of something like the gait and motion scanning allows you that objectivity to then, and also as Emma was saying, the ability to point out and demonstrate to a patient exactly why they're feeling the pain in such a place, but then having the tools through the K laser to be able to go and reduce that inflammation at the same time, start accelerating some of that good quality healing. I think it exemplifies how good technology can be used diagnostically and also on the whole therapeutic side of things in combination with the right hands. So yeah, I thought they were great case studies that you've did, and thank you for the effort of putting those together.
No
I
problem.
did see some of the stuff on there. Sally was asking about whether you could use K laser alongside metalwork. And you can definitely use it with intermedullary, cerclage, screws. All of those things are fine. The only thing you've got to be a bit cautious is if you've got a tibial fracture and you've got a big, thick metal plate running on the medial aspect of that, you need to laser from the contralateral. Otherwise, you're just going to get reflection straight off it and get hot skin, and it won't penetrate through metalwork. So, but it's fine with other bits and pieces of Meccano that's been put inside someone.
I'll just go through a couple of these questions. Actually, whilst we've got a captive audience still, Jamal, whilst I go through these, I don't know if you wanted to mention, I know you've got an opportunity at your clinic at the moment. If you wanted to just mention that, if there's anyone here that's maybe looking for their next opportunity.
Well, thanks, George, for the opportunity to put that forward to the audience tonight. But yes, we are at the moment looking for a physiotherapist to join the team full time, employed, as I mentioned before, we are a team and we work incredibly well together. We have amazing facilities. Some of the facilities we have are the envy of many a clinic because we share a lot of our facilities with the Olympic team. And we have such varied sort of cohort of patients from the elite athlete all the way down to your 9-year-old gymnast and everything in between. So yes, we are looking for a full-time physio. If anyone is interested in a career move to work with us, we please get in touch.
It's a great location and it's in the beautiful grounds as well. Yeah.
Thank you, Stephen.
Emma, is there any comments from yourself in regards of other aspects? I know we're talking specifically really about musculoskeletal and pain management, but I know that you and I have met recently and we've done some training in regards of some of the other more ablative aspects of the laser, and I don't know
Mhm.
whether you've got any comments on that.
Yeah, loads. I mean, I stuck to the MSK side because of the, the GMT and the K laser collaboration. But yeah, we use the K laser to great effect with onychomycosis, as you alluded to in your presentation, Stephen. We're getting some really good results, and we're doing some extensive work on onychomycosis, as you know. And we have done some training recently, very recently, to do some ablative nail surgery techniques, which are very early still. So watch this space, but we're still getting to know it as a surgical instrument, but are having some great results. We're getting people through now. The ones you came to see with us in December are all healed up. Very happy. So that's good. The two we did together, they're
And
healed.
very active individuals as well.
Yes, they decided that they were going to go play golf or running, respectively, the next day, which was fun. So there was some slight delayed healing, but still, they're both healed up as of last week. So that's great. And yes, we're performing on average about 2 a week now. We're selling it. It's very easy to sell because the enhanced healing times. So watch this space. I don't have a lot of data to give you right now because it's still new to us, but it's certainly looking very promising, and it's really exciting to be sort of right at the forefront of delivering nail surgery without phenol, which is quite an exciting prospect because those of you who know, if you know, you know, right? Phenol can be a bit of a blunt instrument, although effective. But if we can improve our patient outcomes and healing times, why wouldn't we? So I'm really looking forward to harnessing some great results from that, and I will report back as soon as I have something more tangible and a bit juicier to tell you. But from my experience so far, it's been great.
No, I appreciate that, and I also thank you for being candid and showing some of your figures for Footscan and for K Laser, and showing what that means financially, because we are all small businesses, and it's great having good technology, but you also do need to make sure it's financially viable as well, and profitable. So,
well, exactly. I'm always quite candid when it comes to that sort of thing. It's not a conversation I shy away from at all because it's important. Being a business coach, I think we need to make sure we know our numbers and something economically viable for your business. How much money is it going to make you? What's your return on investment going to be? These are smart business choices you have to make. But I would say if you're jumping in with new tech, you've got to use it. And these are two, I would highly recommend both of these pieces of tech to add enormous value to your patient outcomes, but value to the bottom line as well. So I'm very happy to speak to anyone if they've got any questions about that. I would also say, sorry, this is a bit of a shameless plug, but I'm also looking for a team member. So if anybody fancies I'm so sad. My lovely Edward handed his notice in yesterday. He needs to.
Ed.
I know, we love Ed. Yes, he has some family things he needs to attend to, so he's making the right choice for himself, and I'm delighted to support him in that. So I am looking. So if anybody knows of a podiatrist, this happened yesterday, so this is very new for me. If anyone wants to move to Cheltenham or knows anybody in the Gloucestershire area that might be looking for a full-time employed role in a progressive team, do let me know.
This is turning into a recruitment campaign.
It is, yeah. We need you.
I'm going to fire a clinical question at you now, Emma, that's come through from Charlie. I won't read full names out just in case people don't want to be identified with their questions. Okay. Hi, Emma. Thanks for the very interesting case studies. I have some patients with cavoid and thuddy gait. I want to put lateral posting in. How do you tend to do this with fits? Is it the lateral border enhancement or another area / setting you use?
Good question. Okay, so it depends on the foot. And obviously it does, of course it does. It depends if they have a very bulbous sort of style of process. which they tend to. It depends if there's swelling. I would generally use a posting. I find, particularly in the cavoid foot, if you increase the lateral height of the side of the orthotic, it can irritate. That's been my experience. So I tend to keep that low and then use posting and stiffness direction. So I make the medial column much less stiff, more flexible. We'll go with that. More flexible on the medial column, and then really stiffen up that lateral column as well. Again, every foot's slightly different. It depends on the foot, but yeah, in my experience, I would lower the lateral border and make the lateral side stiffer and use a post and a skive.
I think just to add to that, Charlie, I don't think we've spoke before, but obviously in the heel wedging, you can raise up that lateral border. Obviously, it's something that is a suggestion based on the dynamic data, but at the end of the day, it's your choice what you would want to do for that patient. So exactly what Emma said as well. Often we try and avoid raising the lateral border too high because it can start to irritate, which is something we want to avoid. And yeah, by utilizing the flexibility in certain areas to really promote that movement can really help. So thank you for that one.
And a first ray cut as well can help.
Perfect. Jamal's nodding. That means hopefully he agrees with that. One that I can probably answer quickly is Fit's the soft version of insoles you refer to, or a different one. No, I'm guessing this maybe isn't someone using Fit. So Fits, I just grabbed one here very quickly. Traditionally, these are 3D printed with a process called selective laser sintering, SLS. It's kind of seen as the premium version of 3D print in terms of real fine detail of what you can do with the device. And yeah, we launched these in 2018. Fit's Dynaprint is a soft version that we're talking about now. Whereas these are quite rigid shells, they still have some flex because there is a sliding scale of flexible to rigid in here. Dynaprint is literally much more flexible, as you can see. And if you've got a patient that prefers a softer device, this version of 3D printing is called FDM. So it's a cheaper version of 3D printing. I don't want to say it's any worse, but it's a different type of 3D print, but it also enables you to offload certain aspects that you wouldn't really be able to do with a shell like this. So if you wanted to offload certain aspects of the forefoot, we can really start to sync them in here as well. So this isn't actually live yet. The only reason Jamal's actually used this on a patient is usually with new features, we set them out to be beta tested by clinicians that use this technology a lot. And then we refine the software, we take on board what the clinician and patient feedback is. So that has been going on for months. And anyone in this call that has Footscan and offers fits, this will become available in your software in the coming weeks. So just keep an eye on your emails about that.
Charlie's got another comment, doesn't he?
Scroll down.
Charlie, in regards to doing a K-laser trial, they will feel something after one treatment, but it depends on the severity and the levels of pain. But that obviously doesn't mean that you've gone and healed anything. And therefore, if they're, say, an arthritic or even a tendinopathy problem, it's better to do sort of 4 sessions, or 4 to 6 sessions, to really see the full effect of that. And obviously for arthritis, it's not a cure. So you're going to go and, get to, you may even do 6 sessions over, 3 weeks or and continue that on if they're doing better each time. There will become a maintenance for arthritis. But for an acute injury, obviously, if you're combining that with things with insoles, you're combining that with a bit of pain management, all of these combine, you can get a complete return to full functionality, as in what Jamal is doing up at his elite sports clinics. These guys are some of these are getting back on the Olympic rostrum and needing to compete at that level. So to be able to heal to those tendons, will take time. but they'll begin to see changes after 3 to 4 sessions, and clinically they'll feel less pain, which means if you are doing a very controlled program, you can gradually build them up. The hard part is to, from a clinician point of view, is to dissociate pain with healing. And they'll often feel a lot better earlier than actually a tendon or ligaments healing. So sometimes you need to rein them in a bit and remember how long tendons take to heal, so they don't revert and go backwards. And so, there is quite a lot of analgesia you get out of it, but remembering the time it takes for tendons, even with the acceleration they're going to get with a K laser device.
Can I just add to that, Stephen, as well, in terms of our experience at the clinic, seeing both acute and chronic conditions. What we have been finding is that the acute conditions tend to respond really well within a shorter period of time of intensive K laser, and the chronic conditions require more sessions, basically,
Yeah.
to
Yeah.
same response. And also, and I think pretty much every physiotherapist, practitioner in general would agree with this, is that these modalities, are almost never used as a standalone modality. We use them alongside other modalities. So some hands-on treatment, rehab work, strength and conditioning. There's a whole host of or a bigger approach, basically, to dealing with these problems. But those modalities like K laser seems to just give us that massive push forwards in terms of time and response, that almost at times it seems like a massive game changer.
And obviously you don't cut up your patients afterwards, but when we've looked at mice and rat models, it's not just the healing, it's the quality of the healing, that you've got the right type of collagen with the right alignment. Therefore, hopefully your patients aren't breaking down in the same location in the future. Or
I
not.
would second that. The only time I've not had to use co-therapy with the K laser is when I treated somebody with thumb arthritis and hand arthritis. That was almost sort of magical, sort of how quickly that worked and the relief that person was feeling. It was in the winter as well, so perhaps that had something to do with it, with a warming effect that helped. But yeah, the co-therapy, the acupuncture or the heel raise, some sort of offload, as with the K laser, the progress your patients make with the co-therapy is really interesting. It's quite fascinating, really, to how people get better so much more quickly. It's really
There's another
effective.
question for you, Emma, about what's the average cost per session for K laser, and do you recommend blocks of 6 with a discount?
What's the average cost per session for K laser across the UK? I don't know.
No, for you, for your
For
clinic,
me,
I think they're
so
asking.
we charge 95, or gosh, I can't remember. It ends up being about 20 quid cheaper if they have a block booking. But yes, so we do give a small incentive there. But yeah, it's not £95 a session.
I mean, we're in London, and the academy does have 2 sports therapists and a podiatrist working out of it, and we charge 120 for an hour, but that is 120 for an MSK assessment, for the full hour with that person, and using laser if they feel it's necessary. So we often combine it as part of the whole thing, with a slightly lower fee if they're not using it in combination. And then in London we do it in blocks of 4. I recommend 6, but we find it the sweet pot for us in London is 4, because we charge 384 for that, so it's about 96 quid per hour when they're combining that for when they do a block of 4. And sometimes we split that into 8 half-hour sessions if really after that initial hour session they realize they only need to concentrate on the ankle and they don't need a full hour. And so that they'll just come in for a half-hour session. and do it that way. And so that works quite well, and people seem to find that as a nice sweet spot for buying it, but also having that compliance, because you need the compliance to make sure they come back and back and back to really get the full treatment rather than just paying analgesia.
Yeah, we charge up front for it, and then you kind of know they're going to come, and they're going to get good outcomes. So we do let them pay as they go, but you get more drop off that way. So we try and charge up front just to ensure, better outcomes for their money, essentially, because we know that 6 is the right number.
Agreed. Yeah. And if they go for arthritis, it could be a maintenance as well, which might go on, higher levels in the winter and less in the summer. But
yeah, oh, for sure.
Yeah. George, any other questions there? I can see some other ones. I think there's one.
Yeah. One from Ben: would the new fits be used to increase the depth of offloading, such as the second MTPJ in Emma's case? Ultimately, yes. It's one of the beauties of this type of 3D print. You can really see it. I'd say this one here is probably about 2 or 3 mil, but the entire device could be printed higher. So let's say, for instance, it was 5 mil increase raise throughout. Obviously, that sort of thing you could use for like a real leg length discrepancy, but also that then gives you room to offload deeper. So, for example, if you had a 5 or 6 mil thickness, you could then put a delve in that forefoot, 4 or 5 mil, obviously not all the way through because that's going to cause problems. But yeah, it gives you a lot more flexibility, particularly in the forefoot. And yeah, I think in particular when you integrate the 3D scan, obviously you have the ability to sit the 3D scan on top of the device. And you can actually now flip it around. So you're looking at the insole of the foot almost through it, like a opaque sort of style. And you can be really specific with where you want that delve to go. If anyone in this call is not aware of that way of viewing it or integrating a 3D scan, just pop us an email or schedule a call with James. He's having these sort of conversations quite a lot. I'll just pop our support email address in there. By all means, reach out and we'll be happy to answer any further questions about that.
Elizabeth asked a question about cancer. Yes, K-laser is a biostimulator. And when I started in 2011, I did have a few sleepless nights that I was thinking that I might be stimulating a whole load of precancerous cells. Thankfully, that has not happened. In fact, bizarrely, we've got the nice approval for using it post-cancer. So there was a big study done on 101 children with squamous cell carcinoma of the mouth, which showed that we did not stimulate cancer, and it operated differently to normal cells. And so now we actually in the NHS are nice approved for using it post-cancer on certain types of cancer. I can't say every cancer because we haven't tested every cancer, but on almost a pharmacovigilance basis, because of the millions and millions of people who've been treated with it now, we have not seen anything, and nor has any other data to show that we stimulate cancer cells. So it is quite interesting in that respect. So in this case, Elizabeth, if you have someone who's under complete remission, I think you're fairly safe to use K-laser. Okay.
There's another question about how do they compare K-laser and shockwave therapy?
Do you want to answer that? You've got some experience.
Exactly. So we use, I wouldn't put them in the comparison categories. I would put them in the complement each other category.
Yeah.
So a perfect example of that is any kind of tendinopathy, for example, Achilles tendinopathy, patella tendinopathy, etc. Even tennis elbow, golfer's elbow, those kind of conditions. Shockwave is a, plantar fasciitis, by the way, another one. Shockwave is a great sort of modality that is complemented very well with a K laser treatment straight after. So in many of my, well, in fact, nowadays, the majority, if not all of my tendinopathy problems, I treat with shockwave when appropriate, obviously, shockwave and K laser in combination. So they complement each other. They don't compare one better than the other.
Yeah, so one's pro-inflammatory and the other one is stimulating the healing.
Correct.
You sort of juggle the jelly and then set it properly with the laser.
I would concur. I think they're very compatible.
Yeah.
If you are lucky enough to have both a good shockwave machine and a K laser, I think you've got a great combination for really tricky tendinopathy cases. And especially chronic ones where you might be using the shockwave to break up that scarring. I think the laser then helps that reheal properly aligned and properly with good strength so that it's not going to break down. And I've had experience of people in the Premiership where they've had just shockwave on Achilles tendinopathies and they keep breaking down every 3 months. But when they had the combination, then they were not breaking down and they were able to sustain a full high capacity season without any issues.
Yeah, they're laying down the right collagen.
Yeah.
In here, it's not targeted at anyone in particular, but do you always do a foot scan assessment before starting lower limb K laser treatment?
No.
Not always.
Not always. Not always. No, depends.
That's
Depends
an
if
easy
it's
answer, isn't it?
Yeah, not all.
Yeah, if it's mechanical in origin, just trying to think that through. A good example, no, it's not a good example. I'm trying to think of an example, but no. Where would be a good one? A bunion might be a good one, potentially.
Just to help you out, Emma, sometimes what we tend to see is, like, for example, we see some athletes who really biomechanically they're actually spot on. There's nothing wrong with them, but they go their training regime changes all of a sudden. So, and they up their training suddenly from a lower level to a very high level with high reps. And for example, their Achilles reacts for that, yeah, and they end up with an acute tendinitis. So that's not necessarily something that I would put them through a scan or anything because I know there's nothing majorly wrong with that. So I go straight for the treatment to put those symptoms down and a behavior modification, obviously within the training. So those are the cases where you don't necessarily always have to scan first and then treat after.
Yeah, chilblains is another one. That's another good example.
Not necessarily biomechanical as such, is it?
No, not
No.
particularly.
Okay. I've only got one other question that come through beforehand. Again, it's just an open question. Would you tend to use K laser and orthoses in conjunction for something like a Morton's neuroma?
Absolutely. Yeah, absolutely. If it's indicated to use a metatarsal dome, for example, to offload and then to calm down, 100%. Absolutely.
More of a calming down and then I guess almost a preventative therein to stop that.
Exactly. That's the orthosis. Wide footwear, a good supportive orthosis to try and prevent. If we believe that it's going to help to put something in there, sometimes adding more to a shoe is going to make it worse. But if it's an appropriate modality, yeah, and then the K laser to calm it down. I can't think of any Morton's neuromas that I've treated where I haven't offloaded it on some level, even if it's not an orthotic, it's some sort of padding or a palliative pad.
Yeah,
for sure. Yeah, combination works really, really well.
Is there any other question I've got? I don't know, Stephen, if there's any more from your side that have come in. I can't see any others in there.
No, I think we've done extremely well. I mean, that's a long session, so I really appreciate Emma and Jamal for lasting all of that time.
And everyone who's still here as well. Not many have dropped off, so
We've done really well.
Kept me all
Again, I would
important.
say if anyone in the audience is looking for a great physiotherapy job up in Shropshire or a wonderful podiatry position down in Cheltenham, just contact George and myself, and we'll definitely put you in touch with Emma or Jamal.
Perfect.
Thank
Emma,
you.
Jamal, thank you very much for your expertise this evening, and also everyone that's joined us as well. Thanks very much for listening, and hopefully we'll be speaking with some of you guys in future if we've never spoke before. But yeah, thanks Stephen as well for
Thank you,
setting
everyone.
this
Yeah,
up.
much appreciated.
All right, thank
Nice
you.
night.
Yeah.
Bye.
Bye.
Thank you, everyone. Thanks for
Good night.
coming.